Thank you, and good morning, or for some of you, good afternoon, everybody. Just a word of warning, I suppose it's a warning. This is a huge topic, and I have got a huge slide set, and you won't be seeing all of my slides. I have over 100 slides in this set. So a number of them are hidden, and I'll try and remind you or tell you when I'm skipping over detailed slides. I've done this because afterwards you can get the full slide set from the National Collaborating Centre, and then you'll have all the stuff that's hidden. I also will be skipping very swiftly over some of the slides, or even skipping them entirely, because I do want to get in the last section to some of the responses we need to make to this huge topic. So here is the outline of what I'm going to be talking about. I'll touch briefly on what health, equity and inequity is, and then talk about the environmental determinants of health, and particularly ecotoxicity, and then talk about a number of ways in which we see environmental health inequity, and then in section 4 I'm going to talk about actions for environmental justice. So first off, here's a definition going back more than 20 years by Margaret Whitehead, one of the first people to write and write well about this. Differences in health which are not only unnecessary and avoidable, but in addition are considered unfair and unjust. And that's a really important concept, that this isn't just about differences, it's about differences that are unfair and unjust, which is really, if you like, and as it says here, a value judgment. This was a slide originally developed by Jim Frankish, and I added some points in black on the side there. So when we talk about differences in health outcomes, which is how politicians like to talk about this, incidentally, they like to use the word disparity, and they do so because it's a rather dispassionate observation of differences without any moral or if you like, political judgment. An epidemiologist might then decide that or might say, examine it and say, well, some of those differences in health outcomes are unavoidable. The ones, for example, that are related to genetics, to your sex. So obviously, men get diseases that women don't get, and vice versa, because of their anatomy. And then there are those that are avoidable, and those are largely if you like, socially based or sociopolitically based or socioeconomically based. And then the question is, are those differences acceptable or unacceptable? And that is a value judgment. It is not an epidemiological judgment. It's a societal value that we have to talk about. Here's a way that illustrates the difference between inequality and inequity. This happens to be the costs of healthcare by socioeconomic status in Canada from a study a few years ago. But the point I want to make is that there is a gradient across the different socioeconomic groups, and that gradient is relatively even, relatively level, straight, until you get to the lowest group, where it just jumps up above the curve. And so you could argue that perhaps that straight line represents a level of inequality that we might decide is acceptable. We might not. How steep that line is, it's almost never going to be actually flat, but the steepness of the line is something that we can debate. But then when there is this lower socioeconomic group that is, if you like, more than unequal compared to the others, that is inequity. And so that's one way to think about it that I find helpful. I have a couple of hidden slides that would come next that talk about how the WHO Commission on the Social Determinants of Health has approached it. And here's another way to image it. So to a conservative box, the little guy on the right can't see the baseball game. You actually have to give him more boxes in order to enable him to see the game. And so two different notions of what constitutes equality in our society. I think it's quite a neat little diagram. So that's by way of background to say, well, what is this issue of equality, equity, inequality, inequity? I want to go on and talk then about the environmental determinants of health, and actually more broadly we could perhaps talk about the ecological determinants of health, or maybe that's a subset. We've focused a lot in public health in the last 20 years on the the social determinants of health. But in doing that, we've broadly neglected the environmental determinants, and it's not in fact either or. It is both. It is both the environmental and the social, and in fact, of course, they intersect and they interact. So we need to establish that, or re-establish a balance where we talk more about the environmental determinants of health. And here's a reason why. This is what I call my 80-90-100 rule. So 80% of the time we are in North America, and not just North America, Latin America. I was just in Colombia last week. 80% urbanized or more. Latin America is more urbanized than Europe these days. But 90, here's the 90% of the time we spend indoors, which always comes as a shock to people. They don't realize just how much time we spend indoors, but it's huge. And then we, in addition, spend a further 5% in vehicles. So we're actually only outdoors 5% of the time, about an hour a day on average in North America. And mostly, of course, that is outdoors in an urban setting, since we're 80% urbanized. And then finally, the 100 rule is that we live 100% of the time within natural ecosystems. And within that context, and as a bridge to my next point, 100% of us carry a body burden of persistent organic pollutants and heavy metals throughout our lives. Particularly, there's a concern around persistent organic pollutants. So that takes me to this topic of ecotoxicity. What Ross Hall and Donald Chant, in a foundational report on the concept for the Science Council of Canada back in 1979, so 35 years ago, they talked about what they called the enormity of tininess. We're talking about pollutants that are active at very low levels. So estrogen is active at levels of as low as a few parts per trillion, which is why we worry about levels of estrogen in drinking water. But secondly, these levels in bald eagles of PCBs that are 25 to 100 million times greater than the levels in water. So that's bioconcentration. Also, we have multiple chemicals. So as long ago as 2001, Thornton was reporting 196 different organochlorines identified in the tissues of North Americans. And most of this, the source for this comes from food, not from water and not from air. So in Ontario, for selected organochlorines and PCBs, 88% of the exposure is from food. So this is the picture of ecotoxicity, and here is literally a picture of ecotoxicity. In this case, the level of PCBs in the seal fat is 80 million times the levels in the seawater. So this is bioconcentration. This is the impacts of, or this is ecotoxicity. And what are the health impacts of ecotoxicity? What are the health impacts of hundreds of persistent organic pollutants present in low levels from before birth? And what health effects do they have? The answer is we don't know. We probably never will know. We also these days, I think, need to think about nanoparticles as well as persistent organic pollutants as implicated in ecotoxicity, and perhaps also genetically modified organisms. So that when I talk about ecotoxicity, this is what I have in mind, that we're in this soup, or we exist within and we hold within our bodies a soup of persistent organic pollutants and other contaminants. And really what we have here is an unauthorized and therefore unethical experiment, because what we're doing and what the chemical industry has done is we're all being subjected to an experiment. What happens when you expose an entire population to not exposed? So this is an inequitable and unethical use of power by the corporations who are producing and using these chemicals, and by the governments that allow this to happen. So one way to think about environmental inequity right there is this one, that this is an inequitable situation. We didn't consent to this experiment. So let's move on and talk about environmental health inequity. This is from the Center for Environmental Health Equity, run by my friend Jeff Masuda, who's recently moved from University of Manitoba to Queen's University. And you can see the definition there. I'm not going to read it out to you, but except to point out that he's talking about unresponsive or discriminatory policies that result in multiple environmental risks among disadvantaged Canadian communities. I guess I did just read it out to you. So that's what he means, and that's what I mean too by environmental health inequity. And so then the question is, well, who suffers from environmental health inequity? And the center that he runs focuses in 3 areas, and I'll touch on these: children, Aboriginal people, and cities, the urban poor. But in addition, we should remember that rural and remote populations can suffer from environmental health inequity, as can ethno-racial minorities, seniors, people with disabilities. Anyone who suffers from social inequity is probably going to suffer also from environmental inequity. And here's an urban explanation of that, which the point of this is to say this is a very old phenomenon. So here's London. So why is London's West End rich? Everyone knows about the West End, Mayfair, Pall Mall, all of that. And why is London's East End poor, the Docklands and all of that? And the answer is that this has been the case in London for centuries, in fact for millennia, and there's a very good geographical reason why. This is the prevailing wind. The wind tends to blow from the west to the east, and this is the run of the river. The river flows from left to right, from west to east as well. And well before we knew about bacteria or toxic chemicals or whatever, people are not stupid, and they land that was upwind and upstream more valuable. And so the rich would buy and move into more valuable land upwind and upstream, leaving the less valuable, more polluted land that was downwind and downstream to the poor. And you can see this kind of pattern in cities, old cities throughout the world, and not just old cities. Hamilton, you can see it too. So generally, what we can say is that the poor live downwind, they live downstream, they live downhill in floodplains and so on, unless the hill slopes are dangerous. And I was just recently, as I say, in Cali in Colombia. You can go to Rio and see the same thing. The favelas, the barrios, the poor areas are up on the slopes because the slopes are dangerous. They're subject to landslips and all the rest of it. They also live on floodplains and other marginal lands. They live near landfills and industrial plants and hazardous sites. They live in damp, unsafe and unhealthy housing. They live in dangerous neighborhoods, and they work in unsafe and unhealthy workplaces. So this is environmental injustice. This is people who are subjected to environmental conditions that most of us would find unacceptable and certainly therefore unfair. And it results therefore in environmental health inequity. So all of these places and all of these conditions constitute environmental inequity. Now, let me move on and talk fairly specifically about one vulnerable group, and that is children. And I want to do so in the context of ecotoxicity, and also, as this slide makes clear, what we're also talking about here is another dimension of equity, which is a very important one, particularly if you think in ecosystem terms or in longer term, and that is intergenerational inequity. Right now, globally, and I'll come back to this point, we are creating an environmental burden, some would say an environmental disaster for our children and our grandchildren and our great-grandchildren. We are heaping upon them the problems that we're creating, and that is described as intergenerational inequity. So this is from the work of Phil Landrigan at the University of Pittsburgh, a noted environmental pediatrician, or pediatrician rather, particularly interested in environmental issues. Children are particularly vulnerable to toxic chemicals, more so than adults. This is for a number of reasons that are highlighted here. They have metabolic systems that are immature, they are growing and developing rapidly, so their organ systems are growing and developing rapidly, which makes them sensitive to disruption, and those disruptions can have lifelong effects. And of course, they have many more years of life ahead of them than adults, so more time for long-term effects to be felt. So for all of these reasons, children are much more vulnerable to toxic chemicals than adults. In addition, these days, they are actually exposed from before birth, so they're born with a body burden of persistent organic pollutants, many of which have not been tested for toxicity, and especially have not been tested for toxicity for children. And so again, this is Philip Landrigan. This was quite recently at a conference that he and I both spoke at, organized by the Children's Environmental Health Coalition in New Brunswick. Information on developmental toxicity is available for less than 20% of the 3,000 high production volume chemicals. That in itself, I would say, is a case of environmental inequity. We haven't bothered to or demanded that these chemicals be tested for developmental toxicity. And so for 80% of them, we actually don't know if they're developmentally toxic. And yet they're detectable in adult breast blood, in breast milk, and in infant cord blood. And so he went on to say the central question in pediatric environmental health research is, what is the evidence that toxic chemicals contribute to chronic disease in children? And he gave several examples where he said there was increasing evidence that toxic chemicals contribute to chronic disease, and he mentions asthma, childhood cancer, male reproductive disorders, and neurodevelopmental disorders. So this, again, is an example more vulnerable than are adults, and the chemicals to which they're exposed have not been adequately tested. So a huge problem. Here's a second huge problem, and I'm not going to spend a lot of time talking about this one. I think it's mostly self-evident. Aboriginal people in Canada suffer the greatest inequity, socially and environmentally. And actually, in the US, the origins of environmental injustice are found in environmental racism, and they talk very plainly in the US about environmental racism, primarily in the context of African Americans. But for us, our version of environmental racism is more obvious when you look at the condition of Aboriginal people. And it extends well beyond the poor water quality that they have in their or the vulnerable environments in which they live, to include the loss of traditional lands and resources, climate change, especially in the Arctic. So Inuit people in the Arctic who are going to bear the brunt of climate change, ecosystem contamination, and there's a famous example of that coming up. And as I've already mentioned, poor quality locations, poor housing conditions, poor water quality we should add to this list. So Aboriginal people suffer very much from environmentals for the period for 2000 to 2009. The important point to note here, of course, is that the highest temperature anomalies are up in the Arctic. And this is why the profound silence of the current federal government on the issue of climate change, particularly as it affects people in the north, is so unjust. So this is an example where Aboriginal people, in this case Inuit people, are being particularly subjected to the impacts of climate change, more so and therefore unfairly so compared to those of us further south. Another example, a very famous one, the late Eric Doyle, who was one of the leaders of research into the levels of persistent organic pollutants in much higher levels, some of the highest levels in the world of persistent organic pollutants in their breast milk, because of their diet, and also because of a process I won't get into right now called global distillation, in which persistent organic pollutants migrate to the north. So that's another example of environmental injustice. And of course, Aboriginal people have Canada's worst housing conditions. This is, and it's getting, should say it's getting worse. I missed a line off there, but you can see here First Nations on the left here, in 1996 in light blue, and in 2006 in dark blue, the proportion of dwellings in need of major repairs for population aged 15 and over. So it has been getting worse for First Nations. You'll also see that is on reserve and off reserve, and Métis and Inuit, particularly for First Nations on reserve and particularly for Inuit, the situation has been getting worse. And you can see the non-Aboriginal population on the right. So we're looking at levels of housing in need of repairs, major repairs, that is more than 6 times as high in 2006 in First Nations. My third big area is environmental, is urban health inequity, and I'm going to just very briefly dwell on a little history. I was in Manchester earlier this year, and Manchester, of course, was the first industrial city, and it had massive problems, and very similar to the problems that we see in the slums and informal settlements around many cities of the world today. I was in one of them just last week in Cali in Colombia, one of the more violent suburbs, or not suburbs, in settlements in Cali. Rapid population growth. You have appalling slums in some places, appalling environments in there, and appalling health status. But that was the situation in Manchester 150 years ago, and there's a set of hidden slides that give more detail about Manchester. But just to give you a sense of the impact of that, infant mortality in Manchester in 1798 may have been as high as 300 per 1,000 live births. And for the offspring of cotton workers in labour and labourers in Blackburn in 1890, so that's a lot before the age of 1. It was very high for all others, 160. So this was before we knew a lot about sterile childbirth and all the rest of it, or disinfection and all the rest of it. The interesting thing is, just remember here, we're talking about infant mortality in the first year of life of 252 per 1,000. This is the situation in Kenya for under 5 mortality, so a bigger population. And in the Embakasi slum in Nairobi, which is one of the worst slums in the world, 250 per 1,000 for under 5 mortality. So actually the situation in Manchester was worse than the situation today in Embakasi slum. So the good news in that, I would add, is that we've actually been able to change that hugely in Manchester, and we should be able to change it hugely anywhere else in the world, because obviously that's no longer the case in Manchester. But in Manchester in 1842, in Chadwick's famous report from the Poor Law Commissioners, life expectancy for mechanics and labourers in Manchester in 1842 was 17 years. So you talk about inequalities in health, you talk about health inequity, and that's what we're looking at on a massive scale. So, and we did a report, and you can find the report at the website link that is shown here, where we looked at urban health inequity. And here's a very vivid illustration of urban health inequity. On the left, you have the Paraisópolis favela in Sao Paulo. Now, Paraisópolis is an ironic name because it means Paradise City, and that's what the local people call their settlement there, their favela. And on the right, Morumbi, which is associated with the University of Sao Paulo, and it seems to me, even allowing for perspective differences, that some of those balconies in that apartment building on the right are larger than some of the houses in the Paraisópolis favela on the left. So it's a very vivid illustration of the line between rich and poor. And that was the issues that we were concerned with. And we we identified 4 key research questions, because we were a network intended to identify research questions around urban health equity. We wanted, and we need research on how to ensure urban social conditions promote health equity, on the added pressure of climate change, on how to put health equity at the heart of urban planning, and how to put health equity at the heart of urban governance. And I'm going to talk about the third of those a little bit, but there again is a bunch of hidden slides that you can get more detail from about our work. So, urban planning, how do we ensure that urban planning ensures equitable access to the benefits of urban life, access to adequate housing, access to safe living environments, and access to the benefits of urban life. All sorts of areas where we see environmental inequity, the time and effort required to get to work. If you live in one of those slums in Rio or in Cali, it's going to take you hours to get to and from work, assuming you can find work. You're going to have very long commutes, and very long commutes worth thinking about represent a form of family and community time deprivation. A 2-hour commute each way is 20 hours per week, and that's the equivalent of 2 40-hour work weeks every month, and 2-hour commutes in those communities is not uncommon. Also, how do you ensure access to shops and facilities and community spaces? How about access to healthcare facilities? Those are some of the challenges for people living in those slums and informal settlements. And we shouldn't think, incidentally, that these are issues confined to slums and informal settlements in the global south. These are also issues for people living in our suburbs. One of the big problems of urban sprawl is lack of easy access to shops, facilities, and community spaces, particularly if you don't have a car. If you are a child or someone with a disability or a senior who can no longer drive, or you're the second member of a 1-car family, your access is very limited, and that includes your access to healthcare, of course, as well. So these are not issues confined only to that. Access to adequate housing, obviously location is key. Access to basic services such as water and sanitation, the same kind of issues we saw with Aboriginal housing. And then the quality of the shelter itself. How do we ensure? Remember that building codes are almost entirely based on health and safety concerns. The origins of building codes were in health and safety concerns. So they're really a public health measure, although we don't always think of building codes in those terms. Here's just a very vivid example of where people have access to or don't have access to toilets in Bangalore in India. And the rich are in the heavy black and the lowest income groups in the light black. So a toilet at home, you can see only about 30% of the lowest income category had a toilet at home compared to almost 100% of the rich. On the other hand, they much more likely to use public toilets, which were not used by the wealthiest 2 groups, or to defecate, in fact, outdoors. So we see all sorts of aspects of urban environmental inequity. A third big category of urban environmental inequity is safe living environments. So issues of transportation, home and leisure safety, who lives in unsafe housing, whose housing is likely to fall down or catch fire, children's safety, the elderly, occupational safety, crime and violence, a huge issue where I just was in Cali, of course, and Medellin, suicide prevention, disaster preparedness and response, all sorts of issues that we need to look at if we want to enhance environmental inequity. And again, not just in the cities of the global south. We have similar problems here. But if you look at particularly the cities of the global south, their means of transport are overcrowded and poorly maintained. There are pedestrians on unsafe roads, well, that also applies, of course, to some of our rural and many of our suburban communities where we don't have sidewalks and where the car is prioritized. Poorly constructed homes, less chance of survival when injured just because they have less access to health services. All of these constitute forms of environmental inequity. Then I'm going to very quickly skip through this, but this is an issue I've had a lot of interest in recently around engaging with nature. There are health benefits, well documented now, of viewing nature, of being in the presence of nature, of actively participating with nature. If you have less green environments, there's quite a body of research that shows that it results in social breakdown, in psychological breakdown, in physical breakdown. And these are studies based on studies with hundreds of studies involving millions of people. A woman called Ming Kuo, you can look up her presentation, you can look up her report, has done a very nice job of documenting that. She came and spoke to us here in Vancouver 3 years ago. And what she talks about is what she calls vitamin G, G meaning green. So if you look at all the benefits of being exposed to vitamin G, we would call it a miracle drug if it was a drug. And actually the same's been said about parks. But again, there's a lot of inequity in access to urban parks. We have inequalities in health that are rooted, well, at least to some extent, in inequalities in access to parks, to recreation opportunities, to vitamin G. Do we have age-friendly parks? Do we have parks that meet the quite diverse needs of ethno-racially diverse communities? These are all issues of environmental inequity in urban planning and how we bring nature to people as well as people to nature. I mentioned Ming Kuo. This is the kind of research she does. On the top left and on the bottom right, you will see housing, which is quite green compared to identical housing or almost identical housing or identical housing that is not green. And what she's done is use this natural experiment, because this is public housing in Chicago. Here's another picture of the sort of housing she looks at. And it's a natural experiment. People end up in one or other because they take the first apartment available. They don't choose where they live in that sense. And so she's been able to document differences in all sorts of ways. I'm going to skip these slides, but you can go back and look at them and go on her website, and she's got quite interesting studies about the various benefits of greener spaces. So girls scoring on tests of concentration and self-discipline, or attention deficit disorder is improved, and so on. And then I'm really going to skip over this one. It's just an issue that's intrigued me recently, which is the question which relates somewhat to nature, but more broadly to art and to the notion of beautiful environments. And I'm not talking here about personal beauty, I'm talking about environmental beauty. So a combination of art and nature and attractive urban and architectural design. Who is it that has an excess of ugliness in their environment? Who is it that has a lack of beauty? That also is preferentially distributed. And so I think that we face a situation of a lack of beauty. I think beauty might be a determinant of health. So how do we, if that is indeed the case, then should we not preferentially create beauty and ensure access to nature and art and beauty in disadvantaged communities? And then one final point about cities. Cities are also exposed to natural hazards, to cyclones, droughts, earthquakes, floods, landslides rather. And of course what we need to remember is that the poor, as I've already said, live downwind, downstream, downhill. They live in all of those vulnerable places. And so they are the people who are most subjected, or most likely to be subjected, to environmental disaster. Of the 63 most populated urban areas in the world who have more than 5 million inhabitants, 39 are located in regions that are exposed to a high risk of at least one natural hazard. And we know that within those cities, the poor are going to be the most vulnerable. And we've seen it in Canada and in Europe with urban heat events, and who suffers in urban heat events. It's the poor, the elderly, the very young, and so on. And then one final take before I move on into talking about some of the solutions is ecosystem inequity. I'm doing a big report, or leading a big report with many colleagues, for the Canadian Public Health Association on the ecological determinants of health. And embedded within that notion is the notion of ecosystem inequity, an appropriation of natural capital that exploits and destroys the environment of others. So it's social inequity, but it also deprives future generations of the resources they need, which makes it intergenerational inequity. And actually, it also deprives other species of what they need to survive. So we're appropriating the resource needs, the life needs of other species. And so that raises yet a third form of environmental inequity, which is interspecies inequity. We are not the only species on the planet, and we don't have any more right to the goods and services of ecosystems than any other species, although we like to think we do. You see it with climate change, where and this is my colleague Sharon Friel and her colleagues. Changes in climatic conditions, we've already talked about a lot of this. The health risk will be greatest in low-income countries, in poor people living in urban areas, in elderly people, in children, and so on. All of these represent forms of environmental inequity. Here's an example of inequity in the ecological footprint. This report from the Worldwide Fund for Nature came out just 2 or 3 weeks ago. The blue line at the top is the ecological footprint of high-income countries such as Canada. The pale blue line at the bottom is the ecological footprint of low-income countries. And the green line, incidentally, that is declining across the slide is world biocapacity per person. So we in the top levels here are consuming far more than our fair share of the planet's resources. And the impact of this on the planet, there has been this is the most recent data, over the 40-year period from 1970, a 52% decline in the health of vertebrate species, in the number of mammals and birds and fishes and so on. It's about half the size, the populations, and this is for about, I think the number is about 3,000 species, 10,000 populations that they look at. The most dramatic decline is in Latin America, a fall of 83% in the Living Planet Index. Very recent report, but also, again, here's the inequity. So high-income countries such as us, we've actually increased our Living Planet Index through conservation, through protection, but we've done so at the expense of low-income countries, where you get a 58% and almost 60% decline, partly because they're exploiting their own resources, but much more importantly because we are exploiting their resources. That's a very profound example of environmental inequity. So, given all of that, what can we do about it? Here are some examples. I'm going to skip very quickly over them. You can read more yourselves, but there are some important principles here rather than a specific action. So one principle or one approach, or sorry, let me just say that this is about environmental justice, and the notion of environmental justice is a social movement in the US as well as an interdisciplinary body of social science literature. I'm going to skip over this slide, and I'm just going to remind you to go back to this slide that the pursuit of equity, the pursuit of the elimination of inequity, the reduction of inequality, is the pursuit of social and environmental justice, and that's the business that we have to be in. One way to do that is through health equity impact assessment. The equity lens in BC's core public health programs is a requirement within the system that we look at the equity aspects of any public health program. There are formal health impact assessment processes. ELF is a research project that I'm a co-director of, run by Bernie Pawley at the University of Victoria, the equity lens in public health, looking at how that equity lens is used in BC. Not in this case in environmental context, but it could be. There is also a recent resource kit and a policy from the Ministry of Health and Long-Term Care in Ontario, and you can get their health equity impact assessment toolkit, and the Wellesley Institute in Toronto has a resource page on health equity impact assessment. So that's just some resources for you to use if you're interested in that. But we can do and we need to conduct not just health impact assessments, but health equity impact assessments. This is some information about the health equity impact assessment toolkit that Ontario has developed. There is also this principle which I touched on when I talked about beauty of proportionate universalism, a phrase that is coming out of the United Kingdom, out of Sir Michael Marmot's review for the United Kingdom following the WHO Commission on Social Determinants of Health. He did a report for the UK government called Fair Society, Healthy Lives, and he makes the point that actions must be universal, but with a scale and intensity that is proportionate to the level of disadvantage. So if you go back to that picture of the three boys watching the baseball game, that's proportionate universality. Everybody gets what they need, but those who have greater needs get a greater resource, a greater input. The urban poor not only suffer environmental injustice for basic needs such as water and housing and so on, but also, as I've touched on, but I think we shouldn't forget, we are more than just physical beings. There are broader human needs of access to nature, access to art, to beauty. In Cali in Colombia, Medellin in Colombia, their urban planning guidelines focus in on this, and I have some slides at the end that I won't get to, but you can look at later, that talk about Medellin's city plan guidelines, and they're focused not just on physical need, but on educational and human development and cultural needs. Very rare in urban planning to hear that sort of language, but very important. So we should preferentially try and create healthier environments for disadvantaged groups, is the implication of proportionate universalism. More public transport. They actually need more public transport because they use public transport much more than the wealthy populations do, because they have cars and what have you. They need more libraries because they suffer already from an educational and deficit. They need more recreational and cultural facilities, more parks and access to nature and so on. So we need to think about not just equality, but equity in access to these resources. And this has to address environmental justice for Aboriginal people. The recent Silcotin decision, which gives the Silcotin people control over their traditional lands, is a huge step for environmental justice for Aboriginal people. We need to be addressing issues of climate change in the Arctic and the impacts on the Inuit and so on. And then we need to be looking at environmental justice for children. And I'm going to end with this, with a couple of quick points about this. But we need to consider environment and environmental justice in the context of child health equity. What can we do to create better environments for all children? And remember, when we get it right for kids, we protect all of us. We protect future generations as well. So we need to pay a lot of attention to issues of environmental determinants of health, ecosystem health, built environments and persistent organic pollutants, access to play and nature. All of these issues affect kids very much. If we get it right for kids, we get it right for everyone. So an example is the idea of an environmental bill of rights for children, which actually was introduced as a bill in the New Brunswick legislature recently. It was before the recent election, and I presume it has lapsed now and will have to be reintroduced. But children should have the right to a toxin-free consumer environment. It shouldn't be, and as it says here, children's rights must trump corporate rights, and we need to get that correct. And chemicals are not people. Chemicals are not innocent until proven guilty. We should assume they are guilty until, well, you can't prove something innocent in quite the same way, but until the evidence is very clear that they are extremely unlikely to cause harm. We need healthy built environments and healthy ecosystems. And we can base all this on the Convention on the Rights of the Child, to which Canada is a signatory. And I mention here the recent New Brunswick bill. And we need to build child-friendly communities. which is, as UNICEF says, the embodiment of the Convention on the Rights of the Child at the local level. So I'm going to stop at that. I've raised a number of issues around more principles for how we approach this issue of environmental justice in our work, and our obligation to this and future generations to redress current issues of environmental inequity. So I guess in the remaining 10 minutes, it's over to you folks.
Thank you, Trevor. So open up. And thought-provoking. You mentioned at one point about GMOs being an example of ecotoxicity, and I was curious in what sense.
Well, I'm just thinking about that in as much as the point about ecotoxicity is that what you have is widespread distribution of a human-made product at low levels throughout the ecosystem. And in a sense, GMOs are like that. And to the extent that GMOs are or might be harmful, not necessarily harmful to human health, incidentally, but harmful to the health of other species, then one might think of them as an aspect of ecotoxicity. So I just think it might be an interesting way to think about GMOs. And not all GMOs, but I get worried about GMOs that are giving plants the genetic material of animals, or vice versa. I think we're fiddling around in dangerous ways there. But to think of it as an act, because once this stuff gets out into the environment, you can't get it back. That, which is another point about ecotoxicity. Once you get nanoparticles or persistent organic pollutants or heavy metals out into the environment, you can't get them back in again. They're gone. They're out there forever.
Any other questions from on site in the room? Just for Lydia? Yeah, hard to know what the political will is for change. I mean, it's great to see that New Brunswick has a bill before election. I'm just curious about the time it might take to make a difference, for change, because there are all levels